All right, well, welcome everyone to this week's lecture. So today what we're going to do is we're going to start talking about epidemiologic study designs. And to put this in context for you, so in the weeks before this, we've talked about how we study the health of populations and the various ways that we can define or operationalize our populations of interest. And then we had 2 weeks, remember, where we talked about different measures of occurrence. So how do we measure health outcomes and how frequently they're occurring in populations? With the 2 key measures that we're going to work with moving on being prevalence. So that's, at a set point in time currently, most often, what proportion of the population has our health outcome of interest. And then incidence, which is really about new cases developing over time. And we learned about 2 different ways to calculate incidence, either cumulative incidence, where our denominator is the population at risk over that period, which does not always work very well for dynamic populations. And then our incidence rates, where our denominator is person time, so how much time at risk did each person in our study contribute. And that's a much more precise way of measuring the occurrence of disease because we know how long our population was being observed for. So we're going to now move from these measures of occurrence to talking about study designs and sort of the context and the ways in which we track people and we collect data and we end up getting the numbers that we need to calculate our measures of occurrence. And then eventually down the road, the ways that we collect data so we can start to understand whether certain exposures are associated with an elevated or decreased risk of a disease or a health outcome occurring. So today, though, we're going to start our discussion of study design by first talking about descriptive epidemiology. And if you remember from the first week, descriptive epidemiology is all about person, place, and time, the who, what, where, when, where of health outcomes. And so we're going to talk about person, place, and time, and then 2 very specific types of study designs, which are under the umbrella of descriptive epidemiology. And then in a few weeks, we're going to move on to our sort of the correlated idea of, or the related idea of analytic epidemiology. So how do we move from just describing our population of interest and the health outcomes that are occurring to really testing hypotheses and seeing if exposures are causal factors for outcomes. So starting with descriptive epidemiology, let's just give a little more background on this. So as we talked about in the beginning, health and disease are not equally or randomly distributed through populations. There are patterns to the way that health and disease occur. And it's the job of epidemiologists to identify these patterns and then to take that next step, as I've been saying, to understand, well, what are the causes of those patterns? Why are some people more likely to be sick than others? So again, the prevalence of disease varies by age, geography, time, race, ethnicity, etc. These are all characteristics of diseases that we need to understand. And to understand this variation, again, we look at who, what, when, who, where, and when, otherwise known as person, place, and time. And that's what we're going to be talking about today. And then, as I said, we can move on from the person, place, and time to ask some more questions of why certain people are sick, and that moves us into the analytic epidemiology types of studies. All right, so today we're focusing on person, place, and time. So person being who is affected by the health outcome of interest, place, where the condition occurs, and time, when or over what period the condition occurred. And these are actually relatively simple concepts that I think a lot of people sort of deal with without even realizing it. I know you guys in your homeworks, I saw a lot of people starting to talk about, locations and during this year or after exposure to this event. So you're already starting to think about person, place, and time. So why do we do these type of studies? So really they form the basis of planning for the provision and evaluation of health services. A lot of descriptive epidemiology happens at our federal health department, so the CDC, and then at our state and local health departments, they want to know how is the health of the population changing over time? What are the critical issues? What's the burden of disease among specific populations? And so with our descriptive epidemiologic data, we can target populations that are in need of health interventions. We can set priorities by saying, the prevalence of this condition is now, this high when it was this high earlier. And we can really start to identify emerging problems. And once again, the descriptive epidemiology is for the most part used in sort of a research or academic context for the identification of questions to be addressed later in analytic epidemiology. So hypothesis generating. So things like, why are African Americans at much more risk for strokes than white Americans? And, why are we seeing a disease cluster in a certain geographic area and not elsewhere? So those types of questions, that's what we mean by hypothesis generating. So we're just going to go through a lot of examples of person, place, and time and pick up on some common uses of them and really try to get you familiar with this idea. And as you move into the homework assignment, the descriptive epidemiology assignment that I posted today, you'll see that that assignment is that you take a health outcome that's of interest to you and start to use data to describe that in terms of person, place, and time. So let's start with person. Let me just think. Oh, we do zoom in. Okay, great. So person refers to any personal characteristics that creates like or similar groups of people. I'm sure you guys could think of a lot of these on your own, but common ways that we group people are by age, by sex, by race, ethnicity, culture, marital status, religion, place of birth, socioeconomic status. You can think of a lot of other ways that we might like to group people, but these are really common ones. And often when we're approaching a health problem or a health outcome, we start by saying, is there variation by age, by race, types of things like that? Because again, that starts to help us understand for whom the burden of the disease is the greatest. And then it leads to questions about, okay, well, why does that population have greater risk or have greater prevalence of this outcome? So I'm going to go through a few of these person characteristics by the outcome of obesity, because that's what I'm most familiar with. All right, so let's start with age. So age is one of the most important factors to consider when describing the occurrence of health or disease. And this is because, obviously, the causes of illness and disease differ dramatically by stage of life. So we're discussing very different health outcomes when we're dealing with young children versus the elderly. We'd be concerned if we start to see diseases of the elderly happening among young children, which you could, say that is happening with diabetes. So let's look at this figure and start to disentangle the relationship between age and overweight and obesity. So to orient you, so among children, overweight and obesity are determined by children's BMI percentile. And I think a lot of you are familiar with the concept of BMI. It's a ratio of height over weight, or weight over height, I'm sorry. And for children, what we do is we end up percentiling, so essentially standardizing those BMI scores. And the idea behind that is that we expect that at different ages, different sort of levels of adiposity or fat are more or less normative. So the best example I always refer to is with teenage girls or adolescent girls. As girls are coming into puberty, it's physiologically very normal and healthy to accumulate more fat mass in preparation for menstruation. So you wouldn't want to have sort of a set BMI line like we have for adults and say, okay, you're obese if your BMI goes over this, when it's absolutely part of normal development for girls to become more obese. So bottom line is the percentile allows that natural variation in children's development to be accounted for when we're thinking about what's obese, what's actually unhealthy. So we have two categories for children. Children who are above the 85th percentile are considered overweight, and then above the 95th are considered obese. And in this example, our obese kids are also part of our overweight kids, because it's just anyone over the 85th percentile. So this figure on the y-axis, we have the percentage or the prevalence of overweight and obesity among children. And then we have three different columns, so representing our 2 to 5-year-olds, our 6 to 11-year-olds, and our 12 to 19-year-olds. So we can see here that, let's look at the overweight and obese kids. Among the youngest age group, we have a prevalence of overweight and obesity of about 27%. And then at 6 to 11-year-olds, it jumps up to 32.6% and 33.6%. So something to notice here, as you would imagine, as children are younger, among younger ages, there is a lower prevalence of overweight and obesity. But actually, interestingly, between 6 and 11 and 12 to 19, there's actually not much difference in this prevalence of obesity. Those two groups have about the same amount of obesity, although there's a much bigger jump between the sort of preschool age kids to the grade school age kids. And we see this similar pattern when we just look at the kids who are over the 95th percentile. So when we start to break down overweight and obesity by children's age, you can imagine that it starts to raise a lot of questions. So, first of all, oh my gosh, already by age 2 to 5, we have almost over a quarter of our population are already overweight and obese. So that sort of raises the question, right, of, well, what are the factors earlier than age 2 that may be contributing to this high level of overweight and obesity among this group? That's one example of how age may inform our discussions. We can also think about healthcare services, right? So we can start to catch kids once they enter school for more systematic policies and programs to address overweight and obesity. And we see that, yes, this is actually a really critical part, because about 1/3 of our kids who are school age in the US are going to be overweight or obese. And so that sets a priority for dealing with this health outcome among this age group. So moving on to thinking about sex. So when we look at differences in health or disease by sex, we have to remember that it may reflect a number of different things. So it could reflect genetic or biological differences between men or women. For example, sex hormones play a large role in metabolism and other, cardiovascular outcomes. It could reflect behavioral differences. Perhaps there are behaviors that are more normative for men versus women. At a certain point, I'll admit to not knowing the statistics now, but smoking, and in certain cultures, smoking is only acceptable among men. So in the US, at least, we saw this huge rise in lung cancer among men in sort of mid-century, because pretty much only men were smoking early in the 20th century. And then smoking among women became increasingly acceptable. And then we saw this second wave of smoking among women. So that's an example of behavioral difference in men versus women. And then societal differences, again, they're sort of based on our culture and our beliefs and the institutions we set up. Men and women are treated differently. And again, there are different expectations and sort of, for better or worse, requirements of behavior. And so some of our differences in disease may reflect those societal differences. I just want to point out quickly sex versus gender. I try to be very careful about this. So for those of you who haven't been exposed to this concept before, the word sex actually, should refer to an individual's biological sex, while gender refers to self-identification by the person of whether they're male or female. I will tell you, we do a pretty poor job about accurately differentiating, sex versus gender in most of our studies. But I hope that with, future populations of public health researchers and practitioners, we become better at this. And many health indicators are reported by sex separately, as we saw earlier, by age separately, and we call this sex stratified. And if you remember last week when we were talking about standardization, one of the things we did was we stratified by our different characteristics. So that's a word you'll see commonly is stratify. It just means sort of break up into groups. And so if we look at our prevalence of overweight and obesity, this is greater than the 85th percentile by children's sex, and I'll admit to not knowing if it's probably actually gender, because I think we asked the kids in most surveys, are you a boy or girl? We asked their parent, are they a boy or girl? So in this figure, what we're seeing is that our first group of columns are all ages of children stratified by sex, and then we actually have sort of a three-way or a two-way stratification, excuse me, where we stratified by both age group and sex. And so let's just look at our overall, because it reflects sort of the similar things about when we look by age. And overall, males, the prevalence of overweight and obesity is higher among males than females by about 3 percentage points. And actually, if we look by age group, we can see that gap is greatest among the youngest children. and then it tends to even out among the older age groups. Okay, so let's talk briefly about race ethnicity, another common person statistic that you'll see. So it's important to realize, and we could certainly have a whole class about this, that race is primarily a social and cultural construct. It doesn't reflect biological differences. And, you know, to point out that fact, many countries deal with race very differently than we do in the US. There's not the differentiation between are you black or are you white. So often when we see differences by race, it's important to start to question, at least in my mind, that, you know, it's most likely the differences we're seeing are due to behavioral factors between these two groups, different cultures, perhaps racism and stigma. There are a lot of reasons that drive differences in health outcomes that we see by race. And in the US, we in most of our health research, we go by the definitions of race that the US Census sets out. So currently the US Census classifies race into 5 major categories. You can see them here. And then there's ethnicity, which is different than race. So the predominant ethnicity in the US is Hispanic or non-Hispanic. So although you don't really commonly see this, really people can and perhaps should identify themselves both by race and ethnicity. So someone can be white Hispanic or white non-Hispanic. They can be black Hispanic or black non-Hispanic. And I really, you know, people always wonder, oh, black Hispanic. And I believe from a lot of the Caribbean countries, Puerto Rico, there are more commonly people who identify as both black and Hispanic than you might see, you know, sort of day to day in the US. They're not as commonly represented. Most often, and perhaps appropriately, we have individuals self-identify their race. So we ask people, you know, how do you identify yourself? And however, there are some new methods that can start to identify genetic lineage. This is called genetic admixtures. So it start to, you know, say, okay, based on your genetic characteristics, you know, you're a certain percentage African American, you're a certain percentage Asian, not African American, I'm sorry, of African descent, Asian, or Caucasian. And there's been sort of an increasing amount of work being done. I think it's really interesting to sort of consider, you know, the differences between thinking about someone's genetic admixture and where their families are from versus the way they present themselves and believe that what their race is, because those can be different. So let's look at, again, overweight and obesity among U.S. children, and this is all ages of children, by race and sex. So again, we're dividing by 2 constructs. And the interesting thing here to me is that, and I think these data are a few years old, so we seek sort of flipped trends by gender, by race. So among white and Hispanic children, the males are more likely to be overweight or obese than the females, but this trend is sort of reversed, and black females tend to be, or the prevalence of overweight and obesity is higher among black females than black males. I will tell you, in some of our newest data, these trends are actually reversing, and we're seeing large increases in the prevalence of obesity among black males, and then while black females are stabilizing, and then large increases in the prevalence of obesity, overweight and obesity among Hispanic females, which I think, you know, those changes really reflect, well, we don't know what yet, but perhaps, you know, different acceptance or responsivity to obesity prevention policies that we've enacted. You know, perhaps there's something with marketing and behaviors, and so, you know, black boys are being targeted for some, you know, obesity promoting behavior. Well, they're not being targeted. If black girls are not being targeted. We really don't know what's causing these flip-in trends, and it's a very interesting question to me. Okay, so let's talk lastly about socioeconomic status. So, you know, I think we talk a lot about socioeconomic status in the world today, and a lot of people don't necessarily know what it's actually referring to. So in the most literal sense, SES, or socioeconomic status, is a descriptive term for a person's position in society. It sounds very, I don't know, if you watch Downton Abbey, you know, the staff versus the royalty. But we certainly have it in the U.S. You know, we have high poverty areas. There's a lot of socioeconomic disparities in the U.S. And SES is most often measured by either one of these variables or a combination of these variables. So looking at a person's income level, their education level, and then their type of occupation. So pink collar referring to traditionally women's work, such as being a secretary, blue collar, which I think you all know, and then there's white collar. And the idea of taking multiples of these measures is that one on their own doesn't always accurately reflect a person's position in society. So, a good example may be you guys as graduate students. So your income, unless you're working a great day job, your income may be fairly low, right? You may take student loans out to pay for school, you're living on a stipend. So your income is fairly low. So if we just measured your income level, you may actually be living in poverty. However, you have a college degree, perhaps your parents own their home and they are doing well. You have other indicators in your life that your socioeconomic status is actually higher, and that this just happens to be sort of a dip in this life period. So you can imagine a number of other sort of combinations of these things where someone may have a very high income, but have a type of occupation that's sort of on a lower level of society. I know plumbers do extremely, extremely well. We probably should have all gone into plumbing. But you can start to see how these things don't always completely correlate. Some other ways that we assess SES when we can't always get it, income and education. We often look at, for children, whether they receive free or reduced price lunch status. That's an indicator of their family's income, whether a family receives food stamps or other benefits, etc. And these are, they're all fairly imprecise measures. Unless you can get someone's tax return, you're pretty dependent on them reporting, what their income is, for example. Okay. So let's look at, see if I can zoom into this. Sorry about that. The prevalence of obesity, here we're looking at adults by annual U.S. household income. So here we're looking at one indicator of SES, which is household income. And again, this is adults. Previously, we looked at children. But on the x-axis, we can see income in thousands, and this is household. And then on the y-axis, we have prevalence or percent. Excuse me. So what we're seeing here is that among women, there seems to be a strong income gradient with obesity. So the prevalence of obesity is highest among those women from the lowest income households. Meanwhile, it drops pretty dramatically among the highest income households. So 35% of women whose household income is less than $10,000 a year are obese, while 15% of women who have a household income over $75,000 are obese. Meanwhile, for men, it's actually very interesting. We don't see very much of a socioeconomic gradient. We may see a dip down here, and we don't know. There are certainly some people with household incomes higher than this, and so we don't know from this graph where that line would go. But it's interesting to think about, right? Why are we seeing this gradient among women? Why is income very strongly correlated with obesity prevalence among women, but for men it sort of doesn't matter what their income is? I think off the bat you can think about sort of social pressures, and that women of higher income may have more time to work out. They may have more access to healthy foods and sort of want to keep up with, society or their neighbors by staying thin. But for men, there's not really that societal pressure to stay as trim. There's not as much of it. So it's, it doesn't matter if you're sort of in a lower income group where everyone's a little heavier versus a higher income group where there's a lot of pressure to stay thin. Okay, so let's start to talk about place. And we've talked about place a lot in terms of how we define our populations. But health and disease and death vary by geographic areas quite a bit. Differences by place can reflect differences in access to healthcare, environmental factors, social factors. And, as with person variables, by starting to look at place, we can identify areas in need, we can track trends over time, and we can start to think about questions about why are we seeing this difference. So we may look in terms of place internationally, across states and cities, urban versus rural, or within states and cities. In the first week we looked within Philadelphia at different zip codes and the prevalence of HIV within those zip codes. So here we can look at a map of the global obesity problem, and as you can see, sort of the US and North America have very high prevalences of obesity, with similar prevalence of obesity in Brazil and Australia, really the developed countries. Oh, in Europe, the wealthier and more developed countries. Meanwhile, the prevalence of obesity is very low in the Asian countries. So you can start to think about, are there genetic differences of the populations that live in these places? Are there different access to food supply and cultural customs around food? There's a lot of questions that these maps can start to raise for you. And finally, let's talk about time. So understanding the changes in health and disease over time allows us to identify whether changes in our society, for better or worse, matter. So are we seeing, as we know that, the prevalence of obesity really increased over the past 3 decades and now it's starting to plateau? That says something about our society and our access to food and our healthcare and other things like that. And also, time is really critical when identifying specific diseases, sources of diseases, and potential exposures. And this is particularly relevant for infectious diseases. So, and we're going to look at something called an epi curve in a second, but time and the amount of time between when people are exposed to something and when they get sick and when they recover and how they pass certain infectious diseases off to the people around them can give us a lot of information about what disease, what organism are we dealing with, are our prevention or treatment strategies working. Bottom line, there's a lot to be learned from time. For an example, you may have, again, the ubiquitous church picnic, and did people start throwing up an hour later or 24 hours later? It start to give you some idea of what might have made them sick and look at specific foods. It adds a lot to the investigation to figure out what the source of the disease is. Okay, so cyclic trends are one specific way that we can characterize time, and cyclic or seasonal trends are the increases and decreases in the frequency of disease over a period of several years or within a year. Often diseases that have cyclic trends are related to environmental factors as well as the natural course of disease. So we know that influenza tends to peak in February. That may shift, of course, with what actual strain of influenza we're dealing with. And that's useful information too, right? Like if we're seeing a peak in October that we haven't seen in previous years, people start to say, uh-oh, this is like a very different disease, and we need to figure out a different way to deal with it. And we know allergies and asthma peak in spring. Excuse me, I apparently have a cold. And we interestingly know that heart attacks most often occur on weekends and Mondays, perhaps because of those weekend warriors. Okay, so a very specific example of looking at time and the incidence of disease is something called an epi curve. And this is very, very simple figure. Here we have an epi curve that is looking at the distribution of cases of BSE, I'm not going to, by date of onset and clinical symptoms. So here along the x-axis we have the date of onset of clinical symptoms, and then on the y-axis we have number of cases. So again, this is just a count. This is not a proportion or incidence. It's not divided by the size of the population. So what we can see is that over this 10-year period, we had a real peak in the number of cases of BSE. And the time that each person is plotted on here is by the first sign of clinical symptoms. And what this epi curve allows us to see is how different policies and practices put into place helps to address the incidence of disease. And so here we can see that in 1988 we started a feed ban. And you can see, though, that feed ban actually didn't seem to do much to curb the new cases of BSE. And then after this peak, the number of cases had already started to decline, where then there was a mammalian feed ban. So a ban on, I'm guessing, the infected cows. To be honest with you, I'm not quite sure. But actually what this is showing is sort of these continued cases and continued increase for quite a while after the feed ban. And then there's a natural decline. So the question now, which we can't get at from this figure, but it certainly raised the question of like, did these practices actually do anything to make a dent? Were they causal factors in changes in the incidence of BSE? Or were they was this sort of a natural cycle of BSE and these policies just happened to occur here? Okay, so there's 3 specific types of time trends that I wanted to introduce you guys to, and these are really important when we're looking at and trying to understand the patterns of health and disease over time. So the 3 time trends that you're going to encounter are age effects, cohort effects, and period effects. And it's important to sort of understand these because sometimes when we're looking at, say, again, the prevalence of obesity over the past 50 years, it's hard to differentiate, is it something about this population? Is it something about size now? Is it something about the age of the group that we're looking at? There's a lot of things about time that often come together when we look at the prevalence or incidence of certain diseases or health outcomes. So the first specific kind of time trend is age effects. So there are differences in health indicators due to aging. This is what you would imagine that, when we talk about time and aging, that as people age, different health conditions come about, different diseases arise. And so you may see, if you're following a cohort or a group of people over time, you're going to see declines and increases in certain types of diseases. And that's an age effect. It's probably that, or in some part in that, the people are growing older. Another type of age effect or a time trend that you may see is a cohort effect. There are differences in health indicators due to the time or generation when people were born. So even at the same age, you may experience different health outcomes for different generations, essentially. So 30-year-olds born in 1900 had a very different health status than 30-year-olds born in 2000. So that's called a cohort effect. So it's something about really the environment in which people are growing up, that the social or physical environment, that even at the same age, 30 years old, let's say, you're seeing very different health profiles of people. The last time trend that we're going to talk about are period effects. And this is when there are differences in health indicators due to factors that vary over time. So this is independent or separate from how old people are, how much they're aging, what year or period they were born in. It's the idea that our environment, produces some things or causes health conditions and then wanes and waxes. And that it's not due to necessarily something about the generation you're in or how old you are, but just the environment that you're existing in and how that's changing health.